Welcome back to my channel. My name's Sarah. I'm a doctor in the UK and I make videos about my life as a doctor in the emergency department and what I get up to in my free time. So today I'm going to film a video about some of the cases that I've seen in A&E. I did a shift yesterday and I just kind of jotted down a few notes for myself after the shift to remind me of the patients that I'd seen and confidentially tell you guys about them. I hope you enjoy it. Let me know what you think. Hey guys, so it's Sunday, it's 5 to 2 and I'm working a 2 till midnight shift today. I'd take you guys along for a shift with me in the emergency department. The emergency department where I work is really vast and it's divided up into lots of different areas. At the start of the shift we report to the consultant in charge and ask where we're going to be working, and today I am here in the urgent treatment unit, which is a bit like an emergency walk-in centre. About halfway through the shift I take my break, and today I've got some homemade butternut squash soup and a load of other snacks with me, and then I get back to work and go and finish off my shift. One of the things that I absolutely love about working in the emergency department is the wide variety of patients and problems that you see. There is never a dull moment. Right, midnight, end of the shift, time to go home. Actually, it's not midnight, it's midnight, and that is another thing that I really need to work on, is getting away on time. It's Monday morning, and one of the joys about being a locum doctor is that you don't have to get up and go to work on a Monday if you don't want to. So I have chosen not to go to work today. I haven't booked any shifts, although I did work over the weekend, so I guess swings and roundabouts. But yeah, so today I've just been pottering about the house, doing all the usual kind of household chores. I've cleaned basically the house from top to bottom. I've even wiped the skirting boards, made all the beds, and it just feels nice to have the house all fresh. I've done a click and collect order. I'm going to go and collect that. I've got some parcels to collect from the post office from when I was out and missed those deliveries. I'm in my workout gear right now, as you can see. I'm going to go and do a workout, and then I'm going to get myself up, dressed, and we can sit down and chat all about my cases that I saw last night, and we can do a bit of discussion about some medical stuff, I guess. So let's talk about a few of the cases that I saw last night. I'm obviously going to keep it confidential and anonymous. So the first patient that I saw this shift that I thought would be really interesting to talk through with you guys was a person who had had a fall a couple of weeks ago. She'd fallen onto her chest and had been seen by her GP shortly after, who told her that she probably had a fractured rib, but there was nothing too serious to be worried about, but that if things got worse she should be seen by a medical professional as soon as possible. So she'd done some strenuous activity today, the pain in her chest got worse, and so she decided to come in and see us and get checked out. Every single patient that comes into the emergency department, we do an ABCDE assessment on. Now, if any of you have done first aid training, basic life support, anything like that, you probably will have heard of ABC. And to be honest, we keep it simple in the emergency department and we still follow that structure. And that's because it works. So A is for airway, B is for breathing, C is for circulation, D is for disability, and E is for exposure and environmental factors. The main things that we worry about with chest trauma are a few life-threatening emergencies, so I'll go through those now. So the first thing that comes to mind when someone has fallen onto the chest, you think about rib fractures, don't you? You see rib fractures a lot in the emergency department. About 40% of traumas have rib fractures associated. It's something that we are very much used to seeing, assessing and managing. And the main thing that we have to remember about rib fractures is that there are some pathologies that come along with it that can be life-threatening, and you need to make sure that you're not missing those and dealing with them appropriately. So the differential diagnoses that come along with a rib fracture are open rib fractures. So that is where you've got a broken bone and that broken bone is piercing through the skin, or the bone itself is just exposed. There's also something called a flailed chest, and that is where instead of just breaking a bone in one point, you've actually got 2 points of breakage. So that bit of bone, that's the bit that's in between the 2 breaks, doesn't actually move with the rest of the chest wall when you breathe. And it's really important to pick that up because they actually may have further complications, and a few of them need surgical repair. Another diagnosis that can come along with rib fractures is a pneumothorax. So that is where you get air in between the 2 linings of the lungs, and it actually starts to compress the lung tissue down. Really important life-threatening emergency that mustn't be missed in the emergency department is a tension pneumothorax. And that is similar to a pneumothorax, where you get air in between the 2 linings of the lungs. In a tension pneumothorax, a one-way valve is created on one of the surfaces of the lining, and more air fills the lung to the point where the lung tissue is completely collapsed. It actually starts to push the heart and the inferior vena cava to the point where you actually obstruct blood flow back to the heart because of the pressure that's building up inside the chest wall. That is an immediate life-threatening emergency, and it has to be dealt with within seconds to minutes. And another thing that we have to pick up with rib fractures is any damage to any other tissues, so lung contusions, which is bruising on the lungs, any damage to the heart, or any other organs like the liver or the spleen. So these were all the things that are kind of going through my mind as the doctor seeing this patient in the emergency department. Now, as you know, I was working in the urgent treatment unit, and that is an area of A&E where people actually walk in. They may be brought in by an ambulance, but they've been assessed that they don't need to be sitting on a trolley in the majors department or in resus. So she was sort of up, walking, talking, and she was fairly well. So with that list of differential diagnoses in my head, I started to do my assessment on this patient. The way that we work, as you may have seen when you go to the doctors, is you take a full history so that you know the story, you know the patient's past medical history, any medications they're on, any allergies, any family history, and you know things like, do they smoke, do they drink alcohol? You find out a bit about their lifestyle, and that helps you build an overall picture of what's going on with this patient and getting you to the right diagnosis, but also giving the right treatment for that patient. You can then move on to examining the patient, and again we stick to an A to E assessment and focus in on the areas that are the most important for that patient. With anyone that's come in with a fall, we tend to do a top to toe examination to look for any other injuries, just to make sure that nothing's being missed. Just going back to the chest and just kind of focusing on that, because that was this patient's only problem. So if any of you are medical students, then this won't be new to you. The way that we examine a chest is quite a systematic approach. We do inspection, which is having a look, palpation, which is feeling, percussion, which is tapping, and auscultation, which is listening with your stethoscope. So there's 4 steps to the chest examination. We just like to keep things really simple in medicine because there is so much to remember, and having systems in place helps you to not forget things. Assessing how that patient's breathing. Is she taking short, shallow breaths? Does she look really breathless? Is she starting to turn blue because she's so short of breath and not oxygenating all of her tissues? I completely exposed the chest. I was looking to see if there was any bruising or obvious deformity. Having a look for any open fracture. So there wasn't an open fracture, there was no sort of tear in the skin, and I could rule out that diagnosis completely. There was no open fracture. Another thing that I'd be looking for on the examination was evidence of a flailed chest. So when I talked about the 2 parts of the rib being broken, when that happens, you actually get paradoxical movement of that segment of the ribs. So say for example these are 2 ribs. I've had a break here and a break here, and when I breathe in, you'd normally expect the chest to expand out. Actually what happens is these 2 segments where it's broken stay still because they're no longer attached to the rest of the bone, and it looks like they get sucked in as you breathe in. And then they appear to move the other way as you breathe out, because again they're not connected to the rest of the ribs. So I had a really good look for that. I couldn't see any segments that looked like they had 2 breaks, so that was helping me rule out the diagnosis of a flailed segment, which is that the name of the where you've got 2 breaks in the rib. The other thing that I was looking for to help me make a diagnosis was any unequal rising of the chest. So if you've got, say, a pneumothorax or a tension pneumothorax, you might expect one side of the chest to rise more than the other, and she didn't have that. And having a look at her windpipe in her neck and seeing, is that central? If you have a tension pneumothorax, where I was talking about the pressure building up and up and up, it actually pushes all of the structures in the chest and pulls that windpipe over with those other structures in the chest. So on inspection, the first part of my chest examination, I couldn't find anything abnormal. The next step was palpation, so having a feel of the chest. I felt every single rib in turn, and I could feel that there was one point of bony tenderness, so tenderness on one of her ribs. When you're having a feel of the chest, you also can assess for chest expansion, and that again is looking to see whether each side of the chest rises equally. You can also have a feel of the skin for something called surgical emphysema, which indicates that there has been a puncture of the lining of the lung, and the air is actually escaping out of the lung into the skin and kind of bubbling under the skin. She didn't have any of those things. The only thing I've found so far is the tenderness on one point of her rib. The next thing we do when we examine a chest is to percuss. Percussion is something that takes a while to get used to, and it is one of those medical skills that you kind of get better as you practice it. So you place a hand on the patient's chest and you tap against it. And the way to get your head around thinking about this is, imagine that you have a big keg of beer. This is how we were taught it in medical school when we were doing our clinical skills. So you've got a big keg of beer and it's half full. So if you put your hand at the top where there's just air inside the keg and you tapped, you can imagine how that would sound. It would sound a bit hollow. And then if you put your hand at the bottom of the keg and tapped against your hand, there would be a different sound, because that would be where all the beer's sitting, and you can imagine that kind of dull sound. And it's the same when you're tapping on the chest, and it helps us to assess whether there is air underneath our hands or whether there's some fluid underneath our hands. And if it sounds too much like there's air, then it can mean that instead of air being in the lungs, it's actually outside the lungs in the tension pneumothorax like I was talking about before, or a normal pneumothorax. If it sounds like it's dull, then it can mean a number of things, but in this case I would be thinking about a hemothorax, which is where blood gets in the lining of the lungs. So I tapped across all areas of her chest and I couldn't hear any difference in the sounds. It all sounded completely resonant or normal. I wasn't worried about a pneumothorax or a hemothorax for this lady. And the final step of the chest exam is auscultation, which is listening with your stethoscope. And this is probably the thing that everyone thinks about as the main event when you're doing a chest exam, because I suppose when we go to the doctors, they always listen to our chest, and that's kind of the thing that you remember when you go to the doctors. There's various things that you might be listening for when you're auscultating a chest, but just going back to this lady specifically, I was listening for any changes in air entry to help me decide whether she had a pneumothorax or not. And again, it sounded completely normal and I had no concerns about a pneumothorax for her. I examined the rest of her body, so had a feel down her back, had a feel of her hips, her legs, listened to her heart and did an abdominal exam to make sure that she didn't have any tenderness or worries about any injuries from rib fracture to any of her abdominal organs, and everything was normal.
So just to recap, we've done our history, we've done an examination, the next step is investigations.
There was no need for me to do a chest x-ray for this lady because the diagnosis I'd come to was a single rib fracture, and we don't actually do chest x-rays to look for rib fractures. They are diagnosed clinically. We do chest x-rays to look for all of the other things that I've just talked about that are serious and life-threatening.
So when we are deciding how to best manage rib fractures and whether these patients can go home, we need to answer two main questions. Can they cough and can they deep breathe? Now the reason for this is to make sure that they are able to aerate their lungs fully and to make sure that they clear any secretions. If they can't do this, then they are at higher risk of pneumonia, which in itself is very dangerous. So we need to make sure that these patients are able to cough and deep breathe before we can safely send them home. And it's for this reason that we need to make sure that they have adequate pain relief on board.
She didn't have any shortness of breath in itself. Once she'd had some decent painkillers, she was able to breathe deeply. So I was quite happy that we weren't going to have to admit her for stronger painkillers and that she could be able to manage at home. The most important thing for this lady in the long term was continuing the painkillers until she was able to cope without them, making sure that she took deep breaths. And the other thing to consider about this lady is, why had she fallen? When I took the full history from her, it turns out she's had a fair few falls in the last 12 months, and her GP had picked that up and he has referred her to the falls clinic. So she's going to be seen and they will find out why she's falling so much and give her any treatment that she might need for that. And the final thing that I did for this lady was to give her some safety netting advice. When you're sending people away, you have some level of risk, and that risk is unavoidable. The risk that you might have missed something, and there's a risk that people can get worse. So we always make sure that we give safety netting advice to let people know that if they do start to go downhill, or if they don't feel that they're getting better in the right time frame, that they can come back, and how to actually seek medical attention for those things and what those things are that they need to look out for. She was quite happy with that plan, and off she went on her merry way with some more painkillers. Guys, I want you to let me know in the comments down below if you find these kind of case discussions useful, because I quite like chatting about these things. I mean, I became a doctor because I'm interested in all of this stuff, and if you are interested in it, then I will try and make more kind of videos like this. Your comments are really helpful to me to know what kind of things you want to see, so do let me know. Give this video a thumbs up if you've watched this far. I've got a couple more cases to talk with you. Okay, so another patient I saw, they had come in feeling really unwell. Feverish, hot and sweaty. They've had diarrhea and vomiting for a couple of days, unable to keep down food and fluids, and they had actually told me that they hadn't passed any urine for about the last 10 hours. So that actually is quite worrying to me, because it means that they are getting to a point where they're really dehydrated, and actually if you're not producing urine, it tells me that you might be going into sepsis or going into shock, where you're not actually perfusing your organs, you're not actually getting enough blood flow to your organs to keep them functioning well, so you're not getting enough blood flow to your kidneys. Now, we see a lot of people in this sort of situation in A&E. We see a lot of infections in A&E. The questions we have to ask ourselves, like I said with the other lady, is it life-threatening? Once we've established that and kind of worked towards a diagnosis, is it something that needs admission, or is this something that can be managed by the patient at home with some decent reassurance, a bit of treatment and safety netting advice to look for what to come back for if things start to get worse? When we're looking at patients with an infection like diarrhea and vomiting, we always want to make sure that we're asking enough questions in the history to try and work out, where has this bug come from? Is it just a winter virus, or is this something that they've picked up abroad? Have they travelled recently? Have they been in contact with anyone who's been particularly unwell? This patient was really quite poorly, and I actually got them transferred from the urgent treatment unit round to the majors department. So you guys have probably heard about sepsis. It's a big medical problem, and it's something that is often in the news. It's an infection in the body where your body creates a massive inflammatory response. So we have something called the sepsis 6, which is something that we use as junior doctors to remember how to investigate and treat people who've got potential sepsis. And again, it's just a really simple method that we use to kind of remember things, so that you're not having to sort of every time assess, do I need to do this, do I need to do that? No, you've got 6 things you need to remember. Make sure those are the fundamentals that are done, and then you can add on anything extra elsewhere, but this makes sure that things don't get missed or forgotten.
Another patient that I saw was an elderly patient who was known to have anemia. Now, we always investigate anemia in the elderly because we worry about whether or not they are losing blood from somewhere. And a couple of things that we think about is whether they're losing blood from their gastrointestinal tract, i.e. do they have an ulcer or maybe even a tumour. Anemia by definition is low hemoglobin. Now, hemoglobin is the part of your red blood cells that carries oxygen. So if you don't have enough of that hemoglobin, then your blood can't carry oxygen as efficiently as it would if you had normal levels of hemoglobin. When anemia becomes severe, you can actually start to get symptoms, and those symptoms align with what you might imagine if you're not getting enough oxygen to all parts of your body. So you can feel really lethargic and tired, generally short of breath and a bit unwell, and some people describe feeling palpitations or chest pain. So this patient was already being investigated for the cause of their anemia by their GP. So it wasn't my job to actually find out what was causing the anemia, but rather to make sure that it wasn't a life-threatening emergency and make sure they weren't profusely losing blood from somewhere, and also to deal with the symptoms that they had that day. Now, this patient was very well informed and had had previous similar episodes to this and knows the symptoms to look out for when their hemoglobin level drops so low that they need treatment. So this patient came in, had an iron transfusion, and then presumably will have been able to have gone home the next day after having that. That's just a sample of some of the patients that I've seen on my shift yesterday. I just wanted to sort of show you guys how varied it is, and show you why I love doing what I do, because you never know what you're going to see. It's really exciting, and I love the fact that it challenges you. I think some people are quite scared about working in GP practices or in the emergency department because of that fact, the fact that you don't know what's going to come through the door. But I actually like that we use a really systematic approach. Whatever the problem is, there is always a way of working out how to get towards a diagnosis for that patient and making sure that you're keeping the patient safe and getting them the right management that they need. The other thing that I love about the emergency department is there's a great team around you. You've got really experienced nurses and healthcare assistants, clinical support workers, as well as all of the other doctors that you're working alongside. There's always someone that you can ask a second opinion from, and I love that about my job. Plus the fact that you're working with lots of other people, it makes it quite a fun environment to work in, even when it's high pressure and very busy, which it always is. My shout out this week goes to Emily22. You commented on my last video and told me that you are a newly qualified ICU nurse, so I just want to say hats off to you. You guys do amazing work, and I really hope that you're enjoying work. Anyway guys, I hope you've enjoyed this video. It's been really good fun filming it, and yeah, I hope you've enjoyed it. I hope you've learned something, and I will see you in my next video. Hit subscribe and hit the bell notification icon so you get a little notification when I next upload, and hit that like button if you've found this video useful. I'll catch you next time guys. Bye.